Hi everyone, my name is Carrie Lynch and I'm the current PGY1 community-based pharmacy resident with the University of South Carolina College of Pharmacy and Hawthorne Pharmacy in Columbia, South Carolina. And I'm here today to present to you my research entitled Pharmacist Perceptions and Willingness to Initiate COVID-19 Point-of-Care Testing in an Independent Community Pharmacy Setting. The authors of this presentation do not have anything to disclose concerning possible financial or personal relationships. Now, the number of confirmed cases of COVID-19 have steadily increased over the past year. You can see that as of April 13th, 2021, there have been 472,310 confirmed cases in the state of South Carolina alone. And community pharmacists are considered some of the most accessible healthcare providers with the qualifications necessary to provide point-of-care COVID-19 testing for patients within their practice sites. And pharmacists practicing in smaller independent pharmacies must face additional considerations when implementing enhanced services like COVID-19 testing. And a systematic review by Gubbins et al. Emphasized that the lack of widespread offering of point-of-care testing in pharmacies and hesitation to implement can delegitimize efforts in the eyes of other healthcare stakeholders. Now, the objectives for my research include 1, to assess pharmacists' attitudes toward point-of-care testing within a pharmacy, 2, determine strategies for providing COVID-19 point-of-care testing to patients, and 3, identify perceived barriers to initiating a COVID-19 point-of-care testing service. Now we have methodology. 80 pharmacists completed a 44-item survey over a 10-week period. Eligible participants included pharmacists over 18 years of age who read English, maintain an active pharmacist license, and are currently practicing in a community pharmacy setting. The survey was part of a larger study of South Carolina pharmacists, and the study received approval from the University of South Carolina Institutional Review Board. This poster does contain preliminary results, and data collection is still ongoing. Descriptive statistics were used to collect demographic information, and the questions in the 5-point Likert scale formatting were analyzed by calculating the mean within each category pertaining to patient and operations related factors and testing follow-up. Factors associated with willingness to implement COVID-19 point-of-care testing were analyzed based on the existence of Community Pharmacy Enhanced Service Network's CPSN required core services. You can see the required core services for CPSN listed on this figure on this slide. Now, this chart contains respondent and pharmacy demographics. You can see that the most prevalent primary practice settings for this study included national chain and single independent pharmacies, followed by multi-store independent, then supermarket, and then finally regional chain. The most prevalent position or professional title for our respondents was manager. And you can see that the large majority of our respondents, 64 respondents, reported not having an active collaborative practice agreement with a physician. This is a continuation of respondent and pharmacy demographics. You can see that the majority of our respondents reported that their primary practice settings have been in operation for more than 20 years. So these are very established pharmacies within the community. The majority of our respondents reported having a PharmD as the highest level of pharmacy training, and you can also see the primary practice hours of operation listed here as well. This graph contains CLIA waiver status across different practice settings. You can see that there is a need to improve CLIA waiver status across all of these settings, but it does seem that independent pharmacies, both multi-store and single independent pharmacies, are most equipped to implement these services based on CLIA waiver status alone. This chart displays willingness to implement a COVID-19 point-of-care testing service based on the existence of CPSN core services. As you can see, it is broken down into 3 categories, and each category contained 5-point Likert scale questions within the survey. The first category assessed patient-related factors that can influence service success, like patient interest and need and willingness to pay out-of-pocket cost. The second category looked at factors that can influence the steps for necessary follow-up, like local physician buy-in and pharmacist comfort level. in counseling a patient after a positive or negative result. The operations related factors category assess the respondent's thoughts on whether he or she believes the staff could handle implementing a new service within the workflow, and if they believe the service would be financially viable. Again, we conducted a Pearson correlation between the pharmacist responses within these categories and the existence of CPSN core services within their practice setting. And based on the p-value, there was a significantly significant correlation for the patient-related factors and testing follow-up categories. This is a figure showing considerations, duty allocations, and courses of actions. Based on our respondents' entries, the most important considerations when implementing this service include staff and patient safety and disruption to existing workflow. Also, they mentioned that the best ways to utilize pharmacy technicians in implementation is for marketing the service, screening and obtaining consent, and for billing procedures. Whereas the pharmacist duties would include administering the test to the patient and interpreting the test result. Respondents also mentioned that the appropriate course of action after a positive COVID-19 test result would be to contact the patient via the telephone and to contact the primary care provider via fax. These are the limitations. Due to the small sample size and inclusion of only South Carolina pharmacists, the generalizability of these findings is limited and may not be applicable to community pharmacists in other areas of the United States. Also, as this study collected self-reported attitudes and behaviors, social desirability and recall bias may be a concern. And then finally, individuals who responded to the survey may differ from non-respondents, therefore resulting in non-response bias. Now for conclusions, independent pharmacies do seem more equipped to conduct point of care testing when compared to chain pharmacies based on CLIA waiver status. However, there is need to improve status across all practice settings. There is a need to develop strategies to implement COVID-19 point of care testing within the pharmacy so as not to interfere with daily workflow, as this is the biggest concern for pharmacists within this study. And then finally, significant correlations were found between enhanced pharmacy status and patient-related and testing follow-up related barriers. Those pharmacies with enhanced services were more likely to report fewer barriers to point-of-care testing implementation. These are the acknowledgements for this study. Thank you so much for attending this session. If you have any further questions, feel free to attend my live Q&A, and thank you so much.